Official welcome to all the attendees for today. My name is Dr. Anoop Agrawal, and I welcome you all for this 51st session of the weekly huddle. I'm an interventional cardiologist at Care Hospital, Hyderabad. I'm joined by my colleague and co-host for this huddle, Dr. Praneeth Palamuri. As most of you know who have been with us for quite some time, the huddle is an unscripted audience level interaction where we address common clinical scenarios and typical case series where we discuss our decision making. So we aim to keep the discussion patient practice oriented. What we do is we typically pick up a topic or a clinical case, like today's is a clinical case based discussion, and we try to restrict our discussion around that. So rather than giving a more generalized overview, we try to restrict more towards what we would do on that particular patient. The basic premise of the huddle is to bring our casual hallway discussion to a more organized platform and share ideas together. While we do welcome science and guidelines, with this huddle, we intend to help a physician translate what is established knowledge to a clinical practice, taking local factors and practice patterns into account. So the approach is more pragmatic or more practical in the sense. We are doing this almost for a year now. We missed a couple of Wednesdays on the New Year, but other than that, since late April 2000 or May 2020, we have been doing it every single Wednesday in the evening. Earlier, we were doing it at 7:30. Now we preponed it to 7 o'clock on Wednesdays. And all of our huddle sessions are recorded, and we keep it posted on YouTube and podcast for other people to look at the archive and listen at their leisure. It is not a speaker and audience model in the way that there is not a talk delivered. Basically, we interact on this particular topic and then we share our ideas and whatnot. The format is I start with this case. I ask my co-host, Dr. Praneeth, for his opinion first, and then I go by the flow and I invite other people in the attendees to share their thoughts. So today's discussion is about this 62-year-old male. He came to me, I believe 2 weeks ago or 3 weeks ago, 3 weeks ago maybe. He is relative to one of our hospital staff, one of our doctors. He's 62 male. He was admitted at outside hospital for 7 days for COVID-related symptoms. By the time his symptoms came, he was already day 4, day 5. He was having some fever and some loss of taste. And he thought because of his cardiac history, he should get admitted. He was discharged 5 days back. And on that day's visit, which was about 3 weeks ago, he was asymptomatic, no any complaints, nothing. That was his day 16 of COVID symptom onset. He was otherwise absolutely fine. All the so-called COVID medications were over, and he was taking his routine cardiac medication. He has a history of anterior wall MI in December 2019, that was pre-COVID, for which he had a primary angioplasty to LAD done, and he had been maintained or dual antiplatelet along with other cardiac medications since then. He does not have diabetes. His LV ejection fraction had been stable about 45 to 50%, and he did not have any episodes of heart failure ever. Even in the previous admission, he did not have any heart failure admission. He recently, after discharge, as he's talking to his friends and colleagues and everything, somebody suggested him that, hey, because you had a stent done previously, you should be on oral anticoagulants because, you know, this COVID thing is making people clot. And because we had a stent before, you should probably be on oral anticoagulants. And that is literally the reason why he comes to visit me to ask. In fact, he has a prescription that he carries which says apixaban 5 milligrams twice daily for him to be taken for 3 months. That was a prescription that he was carrying with me. So he came to me to pretty much ask this question that, hey, because of my previous stent and now COVID recover, should I be on anticoagulant? So I have put in very pertinent labs. I didn't put everything else. We can, if you have any questions about his labs and whatnot, you can ask me. I have at least few numbers with me. I don't have all the numbers. So on day 1 of his admission, which is day, I believe 5 or 6 of his symptom onset, his CRP was more or less normal, borderline elevated. IL-6 was 11 with that reference range of less than 6. D-dimer was 189, which is normal. On day 6 of admission, his CRP went down to 1.3, IL-6 of 4.1, And they are, again, not dramatically different, maybe 50% decrease. D-dimer went up from 189 to 312. During his entire stay, he was treated with the usual antipyretic steroids. He was given a cover for antibiotic because of ongoing fever going on for about 5-6 days or so. He got remdesivir. He was given prophylactic dose of low molecular weight heparin, which is 40 milligrams of Clexane daily, and he was given hydration. During his stay, he was in the room and he was not requiring any oxygen or whatnot. His saturations were pretty good. So this is the clinical case. The discussion point, of course, the patient asked me a very clear question: do I need to be on oral anticoagulant or not? The questions that I have formed is, other than anticoagulant, the kind of antiplatelet strategy in case if we do put him on anticoagulation. If we do not put him on anticoagulation, do we continue with dual antiplatelet or continue with single antiplatelet? Would you do any ancillary investigation to help you make a decision in this form? And any other additional therapy that you think this patient will benefit pertaining to heart and COVID that he's currently not on. I have not listed all of his medications, but you get the picture. Post-MI patients, typically they are on uh, statin, dual antiplatelet, low-dose beta blocker, and a low-dose ARB, along with pantoprazole and whatnot. So that is the usual medication that he's on. So Praneeth, I got the case for you. Let me hear what your thought process is. And then we have a couple of guests in our audience. We'll get their input as well, and we'll go down the list. Praneeth, all yours.
Yeah, so good evening, everyone. So, this case, the way I look at is first I will look at his cardiac status. As a cardiologist, I would try to look at his cardiac status first. So, Agrawal MI 2019 relatively stable, has an intercurrent illness right now. So, post angioplasty, more than 1 year. Ideally speaking, I would try to continue dual antiplatelet therapy because he's relatively young and has a lower bleeding risk. So, I'll try to continue dual antiplatelet therapy versus if I think there is any bleeding risk associated, I will be okay at least continuing single antiplatelet. But wherever there is an opportunity, I try to give him dual antiplatelet therapy and the rest of the cardiac medications to be continued. Now, the question of anticoagulation currently with the COMPASS trial of giving low dose rivaroxaban for the patient with stable ischemic heart disease is something which has come up. But that again, not completely comfortable giving them, also because I want to make sure that the drug compliance is ensured. The problem with giving a low dose anticoagulants is probably going to increase the pill burden, and I fear incompliance because of increase in pill burden. And equally, I need there is needs some more data and guidelines to be established. So for me, at this point of time, we're giving single antiplatelet and low dose anticoagulant in the form of rivaroxaban 2.5 BD still not comfortable. In relation to COVID, where patients are being prescribed anticoagulation, though I am not actively treating and I'm not an expert in managing COVID, what I know is what I share is patients who are having the so-called inflammatory response, being known to be having elevated D-dimer levels, were said to be having thrombogenic potential, and that is where they have been given anticoagulation while in hospital stay and equally continuing for 10 days or 1 month or so, depending on the comfort of the treating physician. For this patient, I think he had a mild COVID infection and he did not desaturate, and even the inflammatory markers did not get elevated. So I don't think he would be benefited more by giving anticoagulation. So for him, I would say whatever he is receiving from the cardiac medications, continue the same medications, and probably for him, I don't think I would be prescribing any anticoagulation. Yes, Anoop.
Perfect. Thank you so much, Praneeth. That was a good way to get started with the discussion. And that mild COVID, the only thing I would add to that mild COVID is this guy got admitted on day 5, day 6, continuing to have fever, although he did not have any other symptoms and his markers were not that bad. But having said that, typically in COVID, we expect by day 5, day 6, the symptoms to resolve. That's the only catch in this particular presentation. But other than that, I agree with you. He doesn't have any so-called markers of bad COVID infection. For whatever it's worth, the hospital did put him on steroids. And they did give him at 7 days, if I remember correctly, 7 days worth of dexamethasone 6 milligrams. So they definitely thought that he should be on steroid, although we can disagree on that. But that is something we are not discussing right now. So let me continue my discussion. I will invite my attendees to share their thoughts about this particular case. May I start with Dr. Deepak first? Dr. Deepak, if you could please unmute yourself and share your thoughts.
Hi. So, if we continue the same discussion, one thing it was surprising is they treated with him with an antibiotic, which I'm not sure why they have treated it. Second thing, as you said, the steroid, maybe like they treated, the new guidelines say if the fever is unrelenting at the 7th day after the symptom onset, maybe there's an indication of steroid. That's what the AIMS guidelines say. But you need to taper off it as soon as possible. So to treat him for 7 days of steroid, I'm not really sure what happened. And his markers are really not correlating with the severity of the disease. So that is one thing. So the new variants which we are seeing, they are behaving peculiarly for the last 1 month or something, which we are seeing. They're behaving differently than the previous wave of the COVID infections. So the markers tend to peak too early, but without the steroids itself, they're coming down. So to just go through the markers and start the steroids on that one may be also wrong. But here that was also not there. So to come to the anticoagulation, so it depends on your institute's protocol. What do you like? What is your definition to admit the patient? So for us, the definition of admission at least requires a basic level of oxygen support, maybe at least 1 liter of 2 liters. So we all agree over a period of time seeing a lot of patients. Any patient who has a lung involvement, definitely it's a concept of immunothrombosis. So there will be a definite amount of thrombosis, whether it's a micro or macro, maybe at the later parts. He will require some sort of anticoagulation. But all the parts of the virtuous triads will be affected in the COVID. As the severity increases, the endothelial dysfunction occurs. The virtuous triad, the more severe patients will be static in the ICUs. So definitely they'll require some sort of anticoagulation. We usually don't change the background of antiplatelets which are kept for the cardiac indications. We'll add low molecular heparin. So our standard dose are 1 mg per kg of like the low molecular heparin. So we usually don't go beyond the dose. I think most probably they have kept it here. So when I can see it, he came at the 16th day after the review. To understand how to keep an anticoagulation for a post-discharge patients, we need to understand the basic course of the each phase of the COVID. You have a viremia phase where they really don't require an anticoagulation unless until they have the previous prothrombotic state, which lasts up to 7 days. From the 7th day to 14th day is the inflammatory phase, where the procoagulant state starts for a COVID patient. So after the 14th day is the phase actually we are finding more and more risk of thrombosis. So how do we anticoagulate? It's a big question for us as well. But any patient who required oxygen during the admission, who had a significant lung involvement on the CT, we're going for anticoagulation definitely. And the duration of the anticoagulation is an again question. On a standard note, we are anticoagulating at least for 14 days. But we have been finding that they are prothrombotic even till 30 days or up to sometimes it's up to 60 days as well. So that is one question for this patient. I would usually go for a routine dual antiplatelets. I wouldn't keep any anticoagulation for him. And rest of them, I think I would leave for the cardiac colleagues.
Dr. Deepak, before I let you go, I have a question for you.
Yes.
So in these patients who are out of the hospital now, for whatever reason they were admitted, certainly not severe or even moderate severe COVID, how do we ascertain now whether they have any so-called immunothrombotic phenomena going on or inflammatory thrombotic phenomena going on at this time when they come to me? They are asymptomatic, they're feeling fine.
It's a big question. So there are various ways. One way is to see the D-dimer values. But I think we have been finding more and more people. We have some people who has 35,000 D-dimer, thousands and thousands of D-dimer, but they didn't have any thrombotic phenomena, and this spontaneously comes down. On the other note, I think we've seen people with normal D-dimer values and getting thrombotic phenomena as well. But we tend to see more and more arterial thrombosis in the young people. Whereas I think venous thrombosis in our experience has been in the elderly people. To assess it, D-dimer definitely, if it's elevated, if it's serially increasing, if it's more than 1 or more than 1,000 in our denomination, then definitely you need to keep a watch on them. But just is it only a D-dimer which will give you an idea? I am not really sure. We have been finding other people also having thrombotic phenomena. I have seen some what do you say in the I think MIT and other the Western societies, they have some formulas to complicated algorithms to calculate the thrombotic burden and these formulas to give anticoagulation or not, but they're really not validated at this point of time.
So in this particular patient, when they come to the OPD, is there any role of repeating some of these markers like D-dimer or whatnot and get a sense of their thrombotic risk?
I'm not really sure. We may do it, but whether it correlates with the thrombotic burden or not, I'm like the risk of thrombosis or not, I'm not really sure.
Perfect. Thank you so much, Dr. Deepak. We'll get back to you as we have more questions. And in case if you do have anything to add later on, please raise your hand or you can unmute yourself. I'm gonna go forward with my discussion. May I have Dr. Vivek share his thought. Dr. Vivek is a senior cardiologist at Narayan Hridayalaya, Gurgaon. He is my senior from All India Institute. Dr. Vivek, you got the case, you got the initial discussion. How would you take this case if this patient were to come to your OPD?
Thanks a lot, Anoop. Am I audible well?
Yes, sir, you're absolutely clear.
Actually, I asked because I am myself recovering from COVID and I've had this nagging cough which hasn't gone away. So, yeah, so I think Praneeth and Dr. Deepak have been wonderfully eloquent and very clear about this. So let me just add a little bit more of theory to this discussion. Practically speaking, I fully agree with them. So as far as I can make out of this case here, even though the fever did extend into the second week, practically speaking, this is mild or mild to moderate COVID at best. The reason to differentiate this is very important because of some recent data which has come, it is still in the pre-publishing stage, but it's already there on the websites of the individual organizations. And this data comes from the platform trials. Just to recap, the platform trials are, worldwide trials for different COVID therapies. NIH is also involved, and some Canadian and UK organizations are involved in that. And so there are three of them. One is the ATAC, the other is RECAP, and the third is ACTIVE. So they had a common eligibility criteria and a common outcome. So that is how they pooled their data. The numbers of people extends into something like 2,500, 3,000, I think. Now, the important part is that platform trials have been finished as far as their anticoagulation arm is concerned. And there are two things which are very, very remarkable in this trial. One is that they took people who were admitted, obviously, and the first part was in severe COVID cases. By severe, people who need ICU care. So in these patients, there were two arms. One was full therapeutic anticoagulation, mostly with LMWH. And the second arm was, either prophylactic or as per the institutional protocol, whatever. So that arm was stopped in January because of futility, because there were more bleeds and no benefit with the therapeutic arm in the severe COVID requiring ICU admission. Okay. Now there was another arm which was moderate COVID. Moderate COVID defined as people who were admitted but not needing ICU. In these people again randomized to either full therapeutic anticoagulation during the hospital stay or prophylactic half doses, whichever, or as per the institutional protocol. The extension into discharge was individual as per the institution. This part has also been stopped because of clear superiority. So I'll repeat again, it has been stopped because of clear superiority of full dose anticoagulation as compared to half dose or prophylactic dose anticoagulation. The bleeding risk in the full dose was something like 1.8 or 2% only. So this part is very clear that moderate COVID does need full anticoagulation while the severe COVID does not need. Now comes the third part, and interestingly, the moderate COVID, there were two arms, in one in which D-dimer more than twice elevated was required, and the other arm it was not required. However, the benefit of full therapeutic anticoagulation was there in all the arms. Now we are left with the mild COVID. So now for mild COVID, actually there are no trials which have been done so far. There are several of them ongoing. So for mild COVID and for patients who are discharged and for subsequent therapies, you must be aware there are several trials going on. Active 4B is one of them, and they all have NOACs or LMWH at half dose. So like typically rivaroxaban 10 mg OD, apixaban 2.5 BD, or dabigatran 75 mg twice a day. So these are being done. One of these trials which had done it non-specifically to everybody has been stopped because of futility. The others which required high thrombotic risk or increased D-dimer to twice the level at least, they are still going on. Now, if I just track back here and discuss mild, because this gentleman seems to have mild COVID. Now, what is the overall impact of D-dimer on the COVID outcomes? We all already know that there is an immunothrombotic risk, which, as Dr. Deepak has so rightly said, that more arterial in younger people, more venous probably in older people. As of right now, the way D-dimer helps you is that if it is elevated to what the Chinese and other people found more than 2.2500, which will approximately, I should say, is about 5 to 6 times the normal level, because there are different lab reference ranges. So maybe 5 times the normal reference range. If it is elevated, that is a significant marker of thrombotic risk. So that is one part. The second part is that a lot of trials and recommendations have said that after discharge, you use the improved VTE risk score with more than 4 being marker of increased thrombotic risk, and to decide whether the person needs further anticoagulant or no. So improved VTE score is more of cancer and pulmonary embolism and prolonged immobility. In practically speaking, in Indian scenario where we are having a lot of atherosclerotic burden, I think diabetes, severe morbid obesity, that is prolonged, severe long-standing diabetes or heart disease, stroke, these are the thrombotic risk factors as far as practically speaking. And there is no guideline for this, but practically this is how I am dealing with it. So if a person who has mild COVID has absolutely uncomplicated course, there is not even a reason to calculate D-dimer for him. Obviously, if he's admitted, it will be calculated. If somebody who has mild COVID has thrombotic risk factors like this gentleman had of anti-revolt December 2019, so definitely there is a reason to calculate D-dimer, and D-dimer is elevated here, although it is only marginally so. It's not even twice, maybe it is something like 1.5 times elevated. So he has had a stable course. He has not gone into the moderate category, and he's been discharged asymptomatic now. Saturations never went down. So all in all, I think he will be protected well from an arterial side immunothrombotic episode right now with his dual antiplatelets, and hence this should be continued as such. Mind you, if this patient had required oxygen support, then I would have probably erred on the side of caution and tried to give a more balanced anticoagulation, such trying to cover the venous side as well. And I would have asked for low dose rivaroxaban or any of the other NOACs along with one antiplatelet. And to my mind, the preference would have been to clopidogrel as compared to aspirin. So this is how, so basically to, to, to put it in a nutshell, I think the three risk modulators in COVID for thrombogenicity are the intensity of COVID, the underlying thrombotic risk, and the level of D-dimer elevation. As far as D-dimer at follow-up is concerned, it probably is not advised anywhere in the sense because sometimes the levels are elevated and they can stay elevated for a long time. Mind you, D-dimer has also an inflammatory marker also. So in the initial part and in severe COVID, it will be elevated, won't have any relation to its thrombotic risk. The other ancillary investigations, there is none. I think in this case, I will just continue and do antiplatelets. I though might like to increase his statin if it's not already to the guideline-based recommendation, because statins have been shown to have potent anti-inflammatory effects and plaque stabilization. So if the person is not on good amount of statins, probably I will increase the dose of statin. Thank you so much.
Vivek sir, before I let you go, there are two follow-up questions on what you described. By the way, two important takeaway points from Dr. Vivek's narration. One is the thrombosis, or whatever you can call it, trials, which there were 3 of them. And they were hugely discussed, I believe, 2-3 months ago. And then it kind of pretty much made a standard of care, which in the last 2 months or so, most of the Western world, including a lot of ICUs in India, they have kind of become the benchmark for anticoagulation. So that is one. And the second is that improved ET risk score that he mentioned. Both of these we will be discussing offline on our WhatsApp group. So if you want to be a part of that discussion, I have shared the link here. You can just join that group, and we will share those links for people to read through, and we can have further discussion on that. So Dr. Vivek, 2 questions. Number 1 is, he had got 2 D-dimers, about 150 first one, about 300 the second one. Now he comes here, he has got a previous background risk of atherosclerosis. Why not do one more time and see if it is still about the same or going down? That will give us a much more confidence of not giving him a drug, because remember, in this particular patient, I have to counteract somebody else's recommendation. Somebody has already recommended him to be on apixaban, and I have to say no. So I need my confidence. That is one. And I'm just trying to play a devil's advocate. Why not just check and see what is there? And if it is elevated, what is the harm in giving a month or month and a half of anticoagulation? That is one. And second, do you ever do high sensitivity troponin in these cases to understand the thrombosis risk? Because we know in a lot of our COVID patients, they have this called either endothelitis or microthrombi. Sometimes it becomes very difficult to diagnose or differentiate either one of out, and sometimes even myocarditis on the top of it, where their troponin levels do elevate a little bit. It literally just is a part and parcel of systemic inflammation where myocardium is also involved. So the question is, will troponin help you in this particular patient, either outpatient or while he was admitted in the hospital, to risk stratify whether this patient would qualify for anticoagulant? And I'm asking you this, I will give you this data. That is ECG, which was done one time in the hospital, it was normal. And his echocardiogram was not done during the last hospitalization. The echo findings that I'm telling you is from his pre-COVID timing. So 2 questions for you. Role of repeat D-dimer, and do you ever do troponin in these cases to risk stratify? Vivek sir.
So excellent and thorny questions, I must say. So yes, the conundrum which we are facing today is this of, what's the harm if I give? To put this in perspective, I don't know about Hyderabad, but I'm in Delhi, and you will be amazed that the standard prescription of the physicians here is extending into 2 pages, about 30 drugs for people. So it's a very difficult question. whether to, the, the, the biggest problem we are facing, the rational physicians, is how to counteract somebody who's already advised. Because let's say that you say, he doesn't need, and tomorrow he develops something, then the moral onus lies on you, because somebody might say, I told you so. So this is the big problem here. So I would fully agree with your dilemma. The only issue is that, let us say his D-dimer comes out to be normal. You're still going to continue his dual antiplatelets. I would definitely do so, because he is at high thrombotic risk right now, and double antiplatelets are definitely required. If his D-dimer is getting elevated, and this I have seen recently with this variant, that the D-dimer starts rising in the 3rd week. And if it is rising in the 3rd week, and let us say now it is things like, maybe 400 or 500, well, now there is a problem in your mind, because whether this is just a nuisance or it is not, and there lies the problem. I would actually say that because this disease is something we still haven't fully understood yet. The other point is that people are dying in India right now, sudden death in 3rd and 4th week because of this disease, and we don't know whether it's arrhythmia, or if this is pulmonary embolism, or if this is a plaque rupture. We don't know. So in that case, I think we can err on the side of caution, if at all, if we do a D-dimer, and if it is, let us say it is elevated 4 to 5 times the normal, then I think we may give him a low dose NOAC and withdraw aspirin out of it. I would not really be very keen to give him 3 drugs when the risk, which we know, is not even palpable in the sense of any formal calculation. How much time to give? Well, the trials which are going on right now for NOACs and aspirin also for outpatient, the follow-up period is anywhere ranging from 3 to 6 weeks. So I would rather, because he's had mild COVID, I would say 3 to 4 weeks of low dose would be sufficient. Coming to the second point of troponin, so that is another excellent question. We in Delhi, we are seeing people being admitted for mild raises in troponin, even if they are asymptomatic, absolutely, with no past history of CAD. So some amount of myocardial injury, especially in elderly people, is expected with this. But definitely, if somebody who is admitted and his troponin is elevated, to my mind, goes into the moderate category. If it does so, then obviously he needs anticoagulation and its continuation in the follow-up period, as I had mentioned earlier. Now we come to troponin rise right now. And this is an excellent idea from you. I mean, I must admit, I had not thought of that. But definitely, if the troponins are found to be elevated right now, it might suggest to me that the basic premise of inflammation is still there. And so it might help him, although again, there is no premise for it. Do remember that there are trials going on with aspirin alone as anticoagulant in the ambulatory phase or the post-discharge phase. So a dual antiplatelet in that sense, I think, should be sufficient as far as the plaque rupture or stabilization part is concerned. Given that his improved VT score would not be high, and he hasn't had a very prolonged convalescence, nor did he have severe COVID, so his chance of venous embolisms are on the lower side. And so overall, while troponins might help me in being more cautious, I do not know how it will help me in changing my decision and adding rivaroxaban or something else and withdrawing one of the antiplatelets.
Thank you so much, sir. We will get back to you as we go on our discussion. The reason why I asked about this particular entity, and I understand overprescription. In fact, that is one of the common problem we are seeing, overprescription of these drugs. But it's like we are not just counting upon how many events. We should also be counting upon the overall morbidity of the event, which means bleed while being on anticoagulant versus an arterial or a venous thrombotic event because of COVID. And as you pointed out that, patients who are otherwise doing okay, they are landing up in major trouble. And to the point where they are not even giving us a chance to react to it. So whether an overreaction to these phenomena is what is worth it, I don't know, but completely ignoring it certainly is not the right way to go. And you give an example that if we do a troponin and if it comes mildly elevated, how does it change? And I don't know if any one of us have got the answer right, but certainly if they come negative, particularly if high sensitivity markers come really negative, then will that increase our confidence of saying that no, you don't need these particular therapies and the risk of harming is higher than the risk of benefit? Those are the thoughts which are going on in my mind. And hopefully next 20 minutes, we'll get other people to share their thought and we will continue our discussion along with it. So let me have Dr. Shankar here. Dr. Shankar has been a regular attendee of our huddle session. He's a senior physician. And Dr. Shankar, I'm sure you are seeing COVID left and right, here and there. This is a patient which would otherwise be somewhere between mild to moderate category. How would you take anticoagulation issue in this patient? Shankar sir.
Good evening to all. Thanks to Dr. Agrawal and Polamuri. We have been seeing many cases. Still, this COVID is it is a predictably unpredictable disease. Everybody is passing through the learning curve. So many of the areas are very gray. As Dr. Vivek has rightly pointed out. So still, it is a gray zone. Certain robust evidence to form guidelines to be there, because now the doctors of fraternity has come to know that there are only 4 things are there to help the patient of COVID. One is early remdesivir in the first week, in the viremic phase. Whether it is acting or not, but it is being convinced by the doctors fraternity and as well as the people also. And second is in the second week, we have got steroids and anticoagulants. And fourth one is high flow nasal oxygen. These are the 4 things I have come to know which are helpful in the COVID management. So still, though it is a gray area, but we are giving steroids only in the second week, the inflammatory phase. When we follow some red flag signs, if they are there, then we give steroids. If the resting tachycardia or sometimes bradycardia, and the oxygen SpO2 is at room air, if it is more than 93%. Here, this case is a stage 1C, because stage 1A is asymptomatic. Stage 1B is symptomatic. Stage 1C is symptomatic, but along with the comorbidities like hypertension, diabetes, coronary artery disease, CKD, chronic lung disease, and so on and so forth. So this patient comes under the category of 1C. This patient, if we follow him up, if there is a resting tachycardia more than 100, and if his SpO2 comes down, the deoxygenation comes more than 3% on a 6-minute walk. For example, if his SpO2 is 97 at room air, it comes down to 94, and then we'll be very much cautious. And the simple test is a complete blood picture. Here we see the lymphopenia. If it is less than 1100 cells per cubic millimeter, or NLR ratio, neutrophil leukocyte ratio, this is very simple. bedside test, any lab can do. So if an NLR ratio is more than 3.5, then that goes in favor of a red flag sign. And other inflammatory markers we do, as mentioned earlier, with as alluded to earlier speakers. If in my practice, if C-reactive protein is more than 100, they mention it is 6. So every infection or inflammatory disease will have raised as a CRP, but we have seen in this over a period of 1 year, the D dimers and the CRP, LDH, ferritin levels are very high, even in the mild cases also. So for certain guidelines, we have cut off these values. If CRP is more than 100 and serum ferritin is more than 500 and a D dimer is more than 1000 and LDH is more than 245 and troponin, just now we have discussed, and troponin, it is here it is very non-specific, because this COVID infection will have myocardial injury. So naturally there will be elevation of HS troponin. So even in myocarditis we get, even in acute myocardial infarction, any acute coronary syndromes, we get this elevated troponin, but serial elevation of troponin gives some importance. So troponin I, if it is more than 2 times the upper limit of the normal, and elevated IL-6, mostly IL-6 we don't advise, because it should be immediately collected and it should be immediately processed in the lab. So there should not be any delay in the transport. IL-6, we have burnt our fingers with IL-6 values. So unless the patient has got hypoxia, otherwise I don't advise IL-6. And I personally be at the bedside of the patient and ask the IL-6 to be done immediately. So these are the other, apart from that, the persistent fever more than 5 days. So if these are the red flag signs are there, then COVID is a thromboinflammation. So naturally we have to combat both inflammation as well as the thrombosis. So here we give steroids in the second week, the dexamethasone 6 milligrams, either per oral or IV. Or 32 milligrams of methylprednisolone divided doses. So likewise, everybody knows hydrocortisone 50 milligrams every 6 hours. So these steroids we give only for 7 to 10 days. Beyond that, we don't give. And regarding the anticoagulants, see, this is thromboinflammation, and we have burnt our fingers many times, because after hospital stay for 5 to 7 days in the hospital, and when we discharge them, suddenly we hear a bad news that the patient collapsed. So post-discharge mortality is very high in this second wave. So since only 4 treatments are there, if you don't give these 4 treatments also, you will be blamed. So how best we can use these 4 agents? So as everybody knows, it is there will be increased fibrinogen, D dimers, there will be prolonged prothrombin time, INR, thrombin time, and even activated plasma thromboplastin time, IL-6 levels, all will be increased during this. So ultimately, there is a term known as COVID coagulopathy. See, many of the cardiologists and physicians, everybody, intensivists, they have come across this COVID coagulopathy. I've seen many cases coming with the DVT, pulmonary embolism, arterial thrombosis also. So, so I may not go into the details. So when the CRP is increased, and there is a lymphopenia, NLR ratio more than 3.5 ILR is raised, then one has to suspect some coagulopathy is going on, and either in the form of venous thromboembolism or myocardial infarction or strokes, the DIC. These we have been seeing a lot in the ICU. So ultimately, the autopsy reports have given that the pathology underlying is microvascular thrombi. So there is intravascular coagulation is there. So the coagulopathy is documented in this COVID. That's why we have to give anticoagulation. But thromboprophylaxis for how many days, it's a gray zone. No clear-cut guidelines regarding the thromboprophylaxis. So what I do in this 1C or moderate cases or severe cases, depending on the EGFR, we do serum creatinine levels, and we do enoxaparin, low molecular weight heparin. I give 1 milligram per kg body weight if EGFR is more than 50 ml. And so depending on the EGFR, the dose of enoxaparin has to be reduced, whether once daily as a prophylactic, that's just now alluded to, or in the severe cases, we have to give BD. So regarding the what I follow is I give mainly for as long as he stays in the hospital, we give parenteral anticoagulants. Then after discharge for 2 weeks, total together 3 weeks, earlier we used to give, but recently one paper has come that once the patient is ambulatory, don't give even anticoagulants also. But still I am worried about, because I told many patients we lost in the post-discharge status. So even in the sleep also they are dying. That may be due to these thrombotic episodes, or the arrhythmias also during sleep. Arrhythmias also quite common in this case. Ventricular arrhythmias, blocks are also common in this case. So we may be losing because of these thrombotic or embolic episodes. See,
Shankar sir, I'm going to just interrupt you for a second. So if we can discuss, what would you do in this particular patient? Would you give anticoagulant, or would you not give anticoagulant in this case?
See, that's what I'm telling. If you don't, here I give only for the 3 weeks.
You will give him for 3 weeks?
No, 1 week in the hospital and 2 more weeks in the post-discharge status.
Well, he got discharged without anticoagulation. For 5 days, he's not on anticoagulation. Should you start now?
Then we have to watch for the D-dimer levels. Then if he is mobile, I don't advise. If he has got only one comorbidity, that is only coronary artery disease, he might be not obese. Chronic smoking may not be there. I think he's diabetic.
He's not diabetic, sir. Hypertensive and heart disease. That's it.
Then the comorbidities are there. So since he has discontinued the anticoagulants, the D-dimer is not very much elevated. We regularly follow up the D-dimer levels, and depending on the D-dimer levels, we will advise anticoagulants in this case.
Perfect, sir. Let me invite discussion from a few more attendees here. We'll just ask about the role of anticoagulant in this particular case. I'm going to speak out the names. If you can hear me, please unmute yourself and share your thoughts about this particular case. Dr. Vamsi Krishna, can you hear me? If you could unmute yourself and tell us whether you would anticoagulate or not and your thought process. Dr. Vamsi Krishna.
Sir, hello, sir. Sir, good evening.
Yes. Hi, good evening.
Am I audible, sir?
Yes, you are audible.
Sir, thanks for the opportunity, sir. Actually, I have been seeing so many patients who are being over-prescribed this anticoagulants, sir, especially in post-COVID patient, in spite of patients having mild symptoms, and even if the patients are in home isolation, when they come to follow up for to a physician or chest physician, so many patients are being prescribed this anticoagulants, especially rivaroxaban. Especially when it comes to this case, sir, I don't feel there will be much advantage of anticoagulation in this patient, as the patient is already on antiplatelets. Patient's course in the hospital was not eventful. It was in mild category of COVID, and the patient was not elevated. So patient may not require anticoagulation. To my understanding, sir, the patient may be comfortable with the antiplatelets that he has been using.
Perfect. Thank you so much, Dr. Vamsi. I'm going to keep continuing my discussion. Dr. Rajender, if you can hear me, could you please unmute yourself and share your thoughts for this case?
Good evening, sir.
Hi, good evening. Yeah, hi, good evening.
Good evening. It's a wonderful discussion. Almost all the points have been discussed. But the only point I want to highlight is if he was truly a mild patient, then once patient is admitted for whatever reason, it is beyond a
Okay, let me take care of the mics of people. Okay, all right. You go ahead, Dr. Rajender. Sorry about that.
So once the patient is admitted, so I will err on the side of the patient being moderate, because if I heard right, he also received remdesivir. So I will err that patient. I don't know about his CD severity index, but I will err on the side of patient being moderate. That's one. And secondly, I will take the biomarkers. I will not take them like a single shot, like not index value. I will try all the biomarkers, pro-inflammatory biomarkers. They have to be followed up. So one at day 3, one at day 7, and probably at discharge. And you have to see the trend. If it's upward trend, it's a peaking trend, or downward trend. So what D-dimer levels, they have consistently correlated with prognosis. Once the D-dimer levels are beyond 1000 in Indian value, there has been a direct impact on prognosis. So if the patient's right now level or anywhere previously it was about 1000, I will put him on prophylactic anticoagulation with Novax, and probably a milder prophylactic 2.5 BD sort of rivaroxaban with a single antiplatelet. And here I didn't understand the concept of, I preferred DPI, dual pathway inhibition, rather than TAPT. I don't know people who are talking about TAPT, but how TAPT will help atherothrombosis, I'm quite skeptical about that. And patient is beyond 1 year line. So that these were 2 points that I will tend to err on anticoagulation, low dose for 35 days with a single antiplatelet, rather than to have a dual antiplatelet, which doesn't have true evidence behind it. Thank you.
Perfect. Thank you so much, Dr. Rajender. Dr. Srinivas Raju, he's a senior cardiologist at Care Banjara. Sir, if you can hear me, please unmute yourself and share your thoughts.
Yes, Dr. Anoop, I think regarding the management of COVID, it has been already well discussed. So coming to the platelets for the coronary artery disease, since it's been beyond 1 week of acute coronary, 1 year of acute coronary syndrome, and patient having a low DAPT score, being 62 years and non-diabetic, and LV function, which is only mild LV dysfunction, probably we can manage with only one antiplatelet. My question for all the general physicians was, or my concern is for the patients, our patients who come for follow-up, what is the dose of NOAC which we give to prevent the prothrombotic state? Is it 10 milligrams of rivaroxaban once daily, or 2.5 mg twice daily, or either of them? Does it matter? Can anyone answer that question?
Yes, Srinivas, sir, that will get it answered. We have got a detailed document about that. We'll get that question answered, but thank you for your comments. Dr. Mallikarjun, if you could hear me, if you could share your thoughts. Last comment we'll take, we'll go to questions after that.
Yes, sir. Very good evening to all of you. I am Dr. Mallikarjun. I hope I'm audible, sir.
Yes, you are audible. Yes.
Sir, regarding this case, which appears to be a mild COVID with not much increased pro-inflammatory as well as D-dimer, I don't think any anticoagulation is required for this patient. Had it been a moderate or severe COVID, then the question would arise whether to go ahead with DAPT plus and NOAC, or we should change to single antiplatelet plus NOAC. And one more point needs to be discussed in this scenario is, for example, had the patient is only 6 months post PTCA and on ticagrelor with moderate or severe COVID, what would be the strategy that I wanted to know from the panel, sir? For example, a patient who has developed LV clot with recent MI, where we change to clopidogrel and aspirin and add a anticoagulant. In that way, we should treat, or how would be the approach? I wanted to know from the house.
Perfect, Dr. Mallikarjun. We'll get your question as well. Okay,
Sure.
let me actually read through some of the questions which have been put up here, and then maybe in the next few minutes we'll be done. And Dr. Vivek, I'll come back to you as well. So the question that I see on the chat box, and if you have any other question, please write it on the chat box. I will read it out over the next few minutes. The first question is, what is the dose of NOAC you would use to prevent prothrombotic state in COVID patients? So Srinivas, sir, this question has been actually very elegantly answered by Dr. Vivek in the document that he has prepared for doctors. It's a single page customized document that Dr. Vivek has written. I'll share it with you on the WhatsApp group as well. It actually gives a pretty good idea of when to start, when not to start, what dose to give, and the duration and everything. So I'll share that document with you. I believe, and I'm pretty sure that that document will take care of the problem.
Sure.
Second question is, should we do HS troponin in all patients with cardiac background with COVID? So Dr. Deepak, if I can bring you back in here, just in 1 minute, if you could answer these two questions briefly. HS troponin for all with cardiac background, that is one. And second is, when you do put patients on anticoagulant, for how long you give them prescription for when they get discharged? Two questions, Dr. Deepak.
Yeah. First thing regarding HS tropi, we have been, I think, I had a unit where I think we have 2 or 3 things we do. One thing is the HbA1c we do regularly. Second thing is, in a cardiac patient, we will assess whether he is a recent cardiac, there's a recent history of cardiac event, or is it a chronic cardiac event which is reasonably stabilized. We assess the stability of the cardiac disease, but we don't routinely do an HS tropi. But we already know that if you do a HS tropi, if it's elevated, then definitely we'll try to be on guard. But again, we have been finding significant in the number of the patients that if they have a high inflammatory syndrome, the tropi also seems to be on the upper side. So we don't attach too much importance in the initial stage. We try to slow, cautiously see the patient. Don't very aggressively act upon it. Second thing is the duration of the anticoagulation in the patients, right?
Yes, sir.
Yes, the duration actually, again, it depends on the how bad your patient is and how significant his disease burden in the patient. We try to assess it like any other risk score, like your MI patients or any other patients. No, at the day of the discharge, we try to assess the 3 or 4 things. One thing is about the home oxygen requirement, all the things. Second thing is the risk of infection, secondary infections, how much steroid he has received. Third thing is the risk of thrombosis. How vulnerable he is. So we try to adapt the scores like Padua and all those scores to it, but we know that they are not designed for this. We try to assess the D-dimer levels at the stage of the COVID where he is discharged. And if he is discharging in the second stage or third stage, we try to ask the patients to get a second D-dimer, assess themselves after 5 days, maybe after 10 days. If it is they're serially elevated and he has a significant disease burden, we try to anticoagulate for more duration. The minimum duration we do in our institute is at least 14 days. But sometimes we, on a OP basis, we follow up and sometimes we do it up to 30 days and sometimes for 60 days as well.
Perfect. Thank you so much, Dr. Deepak. Dr. Vivek, if you have a comment, and I also have a question for you, what Dr. Mallikarjun asked. In patients who are on newer antiplatelet and ecosprin, if they need to be on anticoagulant for COVID, how do you manage that? Dr. Vivek.
Yeah, so I would just go on to the first part about the dose part. So the dose part, the trials which are going on for moderate, mild COVID and for people after discharge, they are using, most of them are using half dose anticoagulation. Some of them are using full dose also, but half dose, which means rivaroxaban 10 OD or apixaban 2.5 BD or dabigatran 75 mg twice a day. Now, I think some people mentioned 2.5 BD of rivaroxaban. Do remember that for rivaroxaban 2.5 BD dose comes from the COMPASS trial, if I am not wrong. And in that trial, it was used in stable, extensive atherosclerotic disease, which means that you had atherosclerotic disease in more than one vascular bed. That, and for it was given for a longer term on a chronic duration. So I'm sure this is not what we are really, trying to prevent right now here. We are more interested in the acute thrombotic risk here. Now the duration, as I mentioned, it is 3 to 6 weeks in the ongoing trials. And part of the reason of this ongoing trials duration is because, rivaroxaban at 10 mg OD was tested in the Mariner trial with the improved VT score and everything. And there it was, I think, given for 35 days or something. So that is the approximate duration which you would want to give. As far as the adding low dose anticoagulation NOAC to a newer DYP like ticagrelor or maybe prasugrel and adding to aspirin, and this, in fact, 1 month out of PCI today, if you have to add a NOAC and 1 month has already been gone, unless there is something really wrong with the PCI, I do not see any need to continue 2 antiplatelets and NOAC in any patient today. So, I mean, I might be wrong in this totally. Probably, yes, if you have somebody who has just undergone PCI for STEMI. But even so, I think if everything was clean, 1 month down the line, I'm sure you can afford, with the newer stents, you can afford to stop 1 antiplatelet, in which case, every time for me, it would be aspirin. And I would then continue the newer antiplatelet as well as the NOAC for the specified time I mentioned.
Perfect. Thank you so much, sir. I think that with this, we kind of come to our end of this discussion. Dr. Vivek, you are joining us for the first time. It is customary for us to ask our guests about feedback for the format of the discussion, not the content. If you could just give us an idea how we can make this better. We have been doing it for a year now, but feedbacks are always welcome.
Well, I don't agree with you, because first of all, I will give feedback about the content, because I think it is my right. And I'll tell you, I've never had such a good discussion from my fellow speakers, and I really picked up so many good points today for COVID management, because I'm not a regular COVID physician. And I would really like to thank you for bringing these people in touch with me. I really learned so much today. As far as the presentation part is concerned, I think it's a wonderful way you've been conducting this, and hats off to you really for that. Thank you so much.
Vivek, sir, you don't mind if I share your anticoagulant document with our attendees here?
Yes, actually it is, I would probably be making little bit changes in it and maybe make a flow chart, because some people have asked for that. So maybe I'll share with you in a couple of days separately, and then you can disseminate it further.
Perfect. I will do that. And for the attendees, if you are not on the WhatsApp group, please join. We will be having offline discussion about it. Dr. Deepak, your comments or suggestions about the format of this discussion, how we can make it better? Dr. Deepak, if you could please unmute yourself and share your thoughts. Okay, maybe we are not able to connect with Dr. Deepak. It's already 8 or 10.
I'm sorry.
Here you go.
Sorry.
Yeah.
Sorry, did I miss something? Sorry.
No, not at all. We just wanted your feedback on the format of this discussion, how we can make it better.
No, that's excellent. I think it's a very informal discussion and it's very comfortable. You can actually drive and just listen without any visual this thing commitment, and kudos to you. Yeah.
Thank you so much, sir. Thank you, Dr. Deepak and Vivek, for joining. Pranit, your closing comments?
Yeah, so the hot topic of COVID and anticoagulation, I like the discussion going through. And thank you, Dr. Vivek, about that enlightenment on those trials and all, and Deepak telling us about practically how they are managing many questions unanswered and many practice patterns. And I think the amount of literature is growing and the practice patterns are also rapidly changing. But I believe right now that assess the patient and whom we think or believe is going to have a risk of thrombosis, trying to take D-dimer or other markers as a marker to gauge the risk, and preferably give low dose anticoagulation because of that fear of bleeding risk. And if you're comfortable, you can even give full dose anticoagulation, but equally keeping them all monitored and advising them and allaying their anxiety. I think that's what I take from today's session.
Perfect, Praneeth. Thank you so much. And thank you all of you for attending and giving your insights. Next week is our 52nd session, and that completes 1 year of us doing this huddle discussion. As you know, a lot of these sessions are already uploaded on YouTube and podcast. The link is there on the chat box. You can use your dead time, like your driving time or gym time or walking time or whatnot, to listen to those. All of those sessions are an hour long, of course, and they do address some of the common topics that we discuss. Next week is special for us, and I wanted to make it a little bit more fancy, but the COVID kind of screwed up all of my plan. So we are back to WebEx meetings. So I would ask my attendees next week to turn their camera on. I would like to see the faces. I would like to take some computer pictures or the digital pictures, whosoever is online. And to all the attendees for 52nd session, I'm trying to get a small token of appreciation. So next time, whenever you, whoever is there online with us, I would like to get their name and their mailing address. We'll try to get something as a gesture for our attendees who have been here with us for quite some time. And thank you all. I really appreciate you all being with us. We know it's a long 1 hour discussion, but hopefully we are learning down the road, and we are gaining something out of it. While I end this session, I hope I will see all of you on the WhatsApp group, where we will continue our offline discussion, and hopefully we will gain more knowledge on this topic. Thank you all for joining, and I will see you next week for another session. Thank you all. Good night, please.